Hello, everyone, and welcome to the announcement of our proposals for evidence-based, nationally accredited staffing standards at UPMC Magee Women's Hospital. My name is Mariah Park, and I have been a nurse at Magee's labor and delivery unit for the past 4 years. This is the first time in history that nurses are proposing staffing standards at a UPMC hospital in Western Pennsylvania. The reality is that laboring women are experiencing more complications and comorbidities than ever before. Induction rates are only increasing nationally, and right now, the maternal mortality rate in our country, and specifically Black maternal mortality, is higher than any other developed country. This crisis touches Allegheny County specifically. We are making these proposals because we cannot address this need without investing some of UPMC's massive profits into staffing standards so we can have more time with our patients and elevate women's and family health throughout our region. My path to nursing was not a linear one, but a persistent through line in my life and what I seek in my career is a strong pull towards genuine human connection, collaboration, and serving others. The connection you share when you help someone navigate something as vulnerable, intimate, and transformative as bringing new life to birth is quite frankly indescribable. Many Magee parents often talk about how much the nurses and providers leave an everlasting impact on their lives. But I don't think they realize just how much they leave an impact on us as well. I am forever changed by every parent, baby, and family I've had the honor of sharing these moments with, and I carry them with me every day. I always do my very best for my patients, but it is a heavy load to carry when you leave work feeling like you could have done more. It is a heavy load to carry when one person's needs get put on the back burner for someone else's more urgent ones. What is often the appropriate choice and prioritization comes at the expense of real people, not just numbers on a census report, but real members of our community doing one of the hardest yet most magical things a person can do, giving birth. They are excited, but often they are scared. They look at you with joyful anticipation, but also with real anxiety for the unknown. And what they often need and crave most is guidance, support, and a grounding voice telling them they are safe, they are brave, and that they will be okay. Because even the healthiest, most straightforward laboring patient is taking a risk to bring forth this new little life. I got into this work to be that voice and shoulder for people in not only their most incredibly happy moments, but also in their most sorrowful ones too. So when current staffing protocols create barriers for me to do just that, when they force me to make decisions between patients that I don't want to make, the moral injury is very real, long-lasting, and it keeps score, physically and psychologically. So what are we proposing? How do we nurses feel staffing can be improved for us and for this community that we serve? It's honestly pretty simple because evidence-based nurse-to-patient ratios that ensure ultimate safety in perinatal units already exist. The Association of Women's Health, Obstetric, and Neonatal Nurses, or A1, has already created specific staffing standards for acute care birthing hospitals like ours that are robustly and thoroughly researched. Many labor and delivery units across the country, including our sister hospital, West Penn, already strive to implement and follow them. They include recommendations such as one-to-one nurse-to-patient ratios for those in active labor, those with epidurals or Pitocin, or those requiring high-risk management for conditions like preeclampsia. A1 recommends this ratio for women on Pitocin, for example, to allow for close cardiac monitoring for both mom and baby, and to allow for close monitoring of uterine overactivity. They recommend a 2-to-1 nurse-to-patient ratio for those undergoing cesarean birth, or those in the immediate postpartum phase. That means a nurse for both the patient and a nurse for the baby. So many people in this city who give birth end up getting induced on Pitocin. They might even experience preeclampsia or other unexpected complications. A1 standards advocate for specific staffing levels that increase patient and nurse involvement in decision-making, provide continuous nursing support, and limit unnecessary interventions. We know that when we have the time with patients, they can really be a part of the decision-making process and feel in control of their experience. I'm so proud of West Penn offering A1 standards to birthing patients, and we want to offer that same one-on-one birthing care for the rest of the women in this city. And it's not just us nurses that feel this way. As a part of our negotiations, we asked for input directly from all of you in the community that we serve. We've already heard from hundreds of women and patients who deeply appreciate the care that they receive from their nurses and providers. But they also voiced concerns about feeling rushed, lacking control, and wanting more time. It's clear that we all, as members of this beautiful community, want to strive to further elevate the high-quality care already provided in this city. I want to be clear. We do not currently use these nationally accredited A1 standards at Magee. For example, I am regularly assigned to 2 laboring patients on Pitocin or who have epidurals. We are so far from these standards that it's almost hard to imagine what work could look like if we accomplished them. But what I envision is getting the time to do the work that I always pictured doing. I envision time to hold and create the appropriate space for that mother giving birth to their stillborn baby. I envision time to work with my patient, petrified with unplanned cesarean birth, through the positions that get them that vaginal delivery they so desperately desire. I envision time to care for that fearful mother who was just diagnosed with preeclampsia and is now having an induction that wasn't quite a part of the plan. I envision time to bask in the joy of meeting that new life for the first time and being privy to those first intimate moments of a growing family. And in a healthcare system so focused on profit, I envision reconnecting with this community that I have the privilege of serving every day. That's what our staffing proposals are all about, bringing the human connection back to healthcare. Thank you. Now, I would like to introduce our next nurse speaker, Ashley Guido.
Good morning, everyone. My name is Ashley Grieco. I'm a registered nurse at UPMC Magee Nurses Hospital. I've been a nurse for 12 years, nearly 8 of which have been in the neonatal intensive care unit at Magee. We are one of the largest level 3 neonatal ICUs, or NICUs, in the country, with over 80 beds, where we care for the most critical newborns across our region. I am proud of the lives that we save at Magee and the futures we support. As you can imagine, this is difficult work. We are not only caring for the baby, but for their family members as well. These mothers and fathers never dreamed of having a preterm. From the moment the baby is born, it is the nurse's duty not only to support that infant, but to also support their families. There are evidence-based, nationally accredited standards that provide ideal levels of nursing care for NICU patients in acute care hospitals in the U.S. And we want to work with UPMC to begin to staff based on those standards. With the current staffing structure, we are often forced to rush from task to task, making decisions to address the most acute needs and then move on to the next. Instead, we want to take the time that we can to provide infants a strong foundation for long-term development. The medical literature shows time and time again that there are necessary practices to ensure the best possible patient outcomes. The amount of time we're able to spend with both our patients and their parents impacts babies' developmental growth and families' well-being for years to come. Let me provide you just a few examples. Now imagine that this is your baby or your grandchild. All infants, not just preterm, need to feel gentle physical contact. They need slow and attentive care. They regularly need skin-to-skin contact, which, through the help of a nurse, is provided by their mother or father. We assist getting intubated babies, meaning they have a tube in their airway to facilitate breathing, out of their warm isolettes to be held skin-to-skin with their parent. This skin-to-skin contact is crucial in neurological development and in forming a trusting, lifelong bond. Skin-to-skin helps stabilize the infant's heart rate, breathing, and blood pressure, which in turn reduces stress and improves oxygenation. This overall reduces risks to the brain, like brain bleeds. Skin-to-skin contact is also proven to decrease the rates of postpartum depression in mothers by giving them the necessary time to bond with their baby. Studies show that the ability to provide skin-to-skin care during a NICU stay provides critical physical, emotional, and behavioral developmental benefits 20 years later. But when staffing isn't appropriate, nurses often do not have the time to get critically ill infants out of bed routinely for their parents to hold them. Further, when our preterm infants are healthy enough to safely learn to feed, it is a time-consuming process. The nurses need to support the infant in learning how to safely suck, then swallow, then breathe. But imagine that you are caring for 4 to 5 infants. They all wake up, one after another, starting to fuss. They want to be fed, to be held, to be soothed, but you are only one person and can only get to one infant at a time. Each baby is only given 5 minutes to wake up fully and feed right then. No nurse wants to cut a feeding short because there are too many patients and too few nurses. It is situations like these that our staffing proposals aim to address. We want to establish the standards set forth for NICUs by the Association of Women's Health, Obstetric, and Neonatal Nursing, or A1. Those standards are 1 nurse to every 2 to 3 newborns requiring intermediate care, 1 nurse to 1 to 2 newborns requiring intensive care, 1 nurse to 1 newborn requiring multi-system support, and 1 or more nurses to 1 unstable newborn requiring complex critical care. UPMC needs to approve our staffing proposal, which many hospitals nationwide already follow. The lives of our patients are in our hands, both when they're in the NICU and after they leave. We have a moral responsibility to make sure there are staffing standards in place that give our newborns the best possible outcome beginning in life.
Thank you for those powerful words, Ashley. Next up, please welcome fellow nurse Alex Levy.
Hey, good morning. My name is Alex Levy, and I've spent my entire nursing career in Magee's emergency room. We all know that Magee is a very special place, and anyone at this table can tell you that. But I want to share with you some ways in which my department is especially different. Unlike basically every other ER in the system, our department census has gone up, not down since the pandemic, and 75% of our patients are women. We're seeing more patients than ever before, and they're often far sicker and with more complex social needs. We come to work each day not knowing how many people will walk through our door and what kind of care they will require, which is why national staffing standards are so important. Last week, I was in charge of our department and everything was flowing nicely. I didn't have a patient assignment and I was able to provide my fellow nurses with breaks for lunch. However, between 1 p.m. and 3 p.m., dozens of new patients flooded in and 5 ambulances arrived. We only have 20 rooms and far more patients than beds. An emergently ill patient arrived, requiring all of her nurses' time and attention. You can see where I'm going with this. Things really do change on a dime in the emergency room. Suddenly, people are lining our hallway in stretchers, and each nurse is required to take on an additional patient. I have to put breaks on the back burner. Instead of being in the department to help, I go out to registration to help triage patients. We don't want anyone sitting in our waiting room without knowing how sick they are and how urgently we need to see them in the back. I get a call from EMS. The patient is en route with a racing heart and a blood sugar so high the glucometer can't read it. There are no rooms and no additional nurses, so I become her nurse. Even though she's in a hallway bed 5 feet from the nurse's station and we're monitoring her vital signs, I cannot give her the attention I want to as the charge nurse. This scenario isn't uncommon these days. Our nurses, doctors, advanced practitioners, and techs are working at absolute capacity, but the volume of people just keeps increasing. What I want, and what I know my colleagues want, is to care for you and your loved ones with intentionality, thoughtfulness, and skill. It's a true privilege to be with someone when they don't feel well, when they're fearful and vulnerable. We want to be able to see you without a long wait time, to explain what we're doing in depth, to answer your call light promptly, to counsel you through what comes next. But those cornerstones of nursing become secondary when you're expected to take on additional patients. You go in, you medicate, you move to the next room to do the same. We're constantly forced to prioritize who needs us most urgently in the moment, while knowing that each of our patients deserves our full attention. We want our ER to be a place where your nurse has enough time to treat you as a full human in all the ways you deserve. Whether you came in for an X-ray on a sprained ankle, forensic evidence collection after a sexual assault, or life-saving care after a miscarriage. Safe staffing is how we get there. A minimum of 1 nurse to every 4 patients, every shift, every day. We're also proposing to utilize the National Emergency Department Overcrowding Survey Score, which will allow us to call in other nurses and ancillary support when the patient volume and acuity requires it. Together, by UPMC committing to invest their massive profits in our frontline workers, we can elevate emergency care in the region. Thank you.
Thank you for sharing your story, Alex. Now we have dedicated lactation consultant, Cecilia Evans. Even though UPMC is still refusing to recognize the lactation consultants who voted to unite with us, they are a part of our union family, and we will continue to fight side by side with them to make sure they have a union contract with national staffing standards.
Hello, my name is Celia Evans. I'm a wife, mom of 3, and a lactation consultant at Magee. I'm here today because I love what I get to do for a living. A little over 20 years ago, I had my first child and I struggled with feeding my baby. I benefited from seeing a lactation consultant and it changed my life. After her support, I felt more educated and empowered as a young new mom. I decided to begin working with new moms to support their breastfeeding journeys. I worked hard to earn a bachelor's degree in maternal child health and lactation. Now, for the past 13 plus years, I've been blessed to be able to help families in my community breastfeed their children. I've worked at Magee for over a decade, and the entire time, I have been told by management, lactation just can't see every breastfeeding family. Let me be clear, Magee's lactation department has always wanted to see every family, but that requires a full complement of specialized lactation consultants. Studies show that early assistance from a lactation consultant is linked to an 80% success rate for exclusive breastfeeding, compared to 40% for those assisted by nurses. When UPMC refuses to staff lactation consultants, they aren't just overworking their nurses, they are denying expert care that will impact the rest of their life. They are denying patients expert care that will impact the rest of their life. I have been in countless situations in which I am seeing a family and I only have a short period of time to address numerous problems and concerns. These families are worried that their baby isn't getting enough milk. These families are worried that they won't know what to do if their baby isn't feeding when they get home. Most families want to exclusively breastfeed, but when they don't have the education and support of a lactation consultant, they are not able to achieve their breastfeeding goals. We have received over 600 responses from our community survey, and I wanted to read part of one from a patient who talked about her lactation experience. When I gave birth to my son at Magee, I wanted to exclusively breastfeed, and I had a relatively uncomplicated pregnancy, so this seemed doable. But my lactation consultant and nurses were really rushed. They only had a few minutes to give me advice about good latches and nourishing feeds, and this made it difficult for me to learn. Meanwhile, I was watching my baby's weight decrease and feeling more and more pressure to supplement with formula. It is so stressful to feel like you already can't get your baby what they need just hours into motherhood and having more time with the lactation consultant would have made a huge difference in helping me start motherhood with confidence and calmness. That comment just breaks my heart, and I want to see something better for our community. Numerous professional health organizations encourage breastfeeding, and the World Health Organization has put forth specific breastfeeding goals to impact public health. The exclusive breastfeeding rates at Magee fall short of these goals. Because the rates at Magee are low, the rates in all of Allegheny County are low. Allegheny County has high infant and maternal mortality rates that are above the national average. In Pittsburgh, Black infants are 6 times more likely to die than white infants. Studies find that breastfeeding is associated with a 33% reduction in infant deaths and can reduce the risk of sudden infant death syndrome by roughly 50%. Breastfeeding also decreases risks for cardiovascular disease and type 2 diabetes for breastfeeding women. Magee delivers half of the infants born in Allegheny County, and families deserve adequate lactation education and support when they have their babies at our hospital. Right now, despite the fact that Magee lactation consultants overwhelmingly voted to form a union, UPMC is refusing to recognize us as a part of the bargaining unit. But we are determined to be in the union and a part of negotiations in order to advocate for our most vulnerable neighbors. We have heard so much input directly from women who have delivered at Magee, and we are determined to provide this region with the lactation support that we know is possible. There are very clear, evidence-based staffing standards that recommend for the number of births we do, we should have an additional 9 lactation consultants at UPMC Magee. So today we are making 2 reasonable proposals to UPMC. 1, recognize the lactation department at Magee as a part of this union. Our entire department, as well as the nurses and advanced practitioners across Magee, are unified in demanding that we negotiate a contract together. 2, we are proposing to hire those 9 more lactation consultants in order to fulfill the staffing guidelines put forth by the most trusted professional organizations in our field. With appropriate staffing, we aim to see every breastfeeding family every day that they are at Magee, improving the level of lactation support for the families of Allegheny County. Part of UPMC's stated mission is to serve its communities by providing outstanding patient care. I wholeheartedly agree with this statement, and increasing staffing aligns with their mission. This is an opportunity for Magee to show Pittsburgh and the surrounding region they are willing to invest in the health of women, infants, and families. Thank you.
Thank you for that moving message, Celia. Now I'd like to introduce nurse midwife Ronnie Getz.
Hi, my name is Ronnie Getz. I am a certified nurse midwife, and I've worked at Magee for nearly 7 years, my whole midwifery career. I became a midwife because I wanted to provide sexual and reproductive health care in a way that would put my core beliefs into practice. For me, midwifery is one of the most direct forms of activism and advocacy to improve the health of our communities. I care for pregnant folks during labor, birth, and postpartum, including delivering babies. Perhaps less well known is that midwives also see patients in an outpatient setting for prenatal and gynecologic care. The following is a familiar experience for many of our community members. You schedule a medical appointment months in advance. You arrive on that day after a harrowing experience trying to find parking, then wait 30 minutes to be seen, perhaps while wearing nothing but a paper gown in a freezing cold room. When your provider finally comes in, things feel rushed. They don't seem to know your medical history. They explain things quickly or not at all. You leave the visit feeling like you didn't have time to address everything you wanted to. I can tell you from experience that healthcare providers are desperate to spend more time with our patients. We want to read your chart thoroughly before we meet you. We want to look you in the eye and really listen instead of stare at our computer screen. We want to address all of your concerns and explain everything in a way you understand. Beyond the basic monitoring and treatment, we want to attend to your emotional well-being and quality of life. We want to build trust so that you feel empowered to make informed healthcare decisions. We want to do all this while maintaining our own healthy work-life balance, not spending countless hours at home preparing for your visit beforehand and completing clinical documentation afterward. The staffing proposals we are presenting today reflect these priorities. Although each department of nurse practitioners and midwives has slightly varied needs, across the board, our advanced practice providers are proposing changes that will allow us to spend more time with our patients. Most outpatient appointments are currently allotted 15 minutes for a return visit, 30 minutes for a new patient. Many departments are proposing a modest increase to 20 and 40 minutes respectively. We also seek to expand the number of providers to effectively distribute the workload rather than stretch us thin. For midwives specifically, our proposal would ensure that we retain our backup midwife on call for busy shifts so that we can give our time and attention to fewer people in labor at once. Lastly, advanced practice providers need time set aside from direct patient care to review patient charts, write clinical notes, and keep up with our continuing medical education. In addition to our time, our patients deserve care informed by experience. Unfortunately, every year we seem to lose more experienced providers than we gain due to burnout. Burnout in healthcare is a direct result of the moral injury we experience every day when we cannot provide the care our patients deserve. But by implementing appropriate patient caseloads and safe staffing ratios to make our work sustainable as a lifelong career, we hope to keep our passionate, skilled, and experienced nurses in the workforce. In doing so, we know that the health of our Pittsburgh community will benefit for generations to come.
Thank you for that message, Ronnie. Next up, we have Nurse Dan Melder.
Hello, my name is Dan Melder, and I am a registered nurse in the intensive care unit for adults at UPMC Magee Women's Hospital. I began working at Magee about 2 years ago as a patient care technician, and I have been working as a nurse on the unit for the last 2 years. From the beginning, this hospital has meant a lot to me. It is a place where people come during some of the most important and vulnerable moments of their lives. I chose to work in intensive care because I wanted to care for the most complex patients who need the highest level of attention and support across our region. In the ICU, every patient requires close monitoring. Small changes matter a lot. Being present, watching carefully, and responding quickly are all essential parts of the care that we provide in the ICU. What draws me to this work is the ability to be there for patients and families during moments that can be overwhelming and to help guide them through it with compassion and skill. Like many nurses, I take a lot of pride in the work that we do. My coworkers are incredibly dedicated, and the teamwork on our unit is something very special. We all share the same goal, to give our patients the best care that we can possibly provide. But staffing challenges can make that harder than it should be. In the ICU, nurses are responsible for a small number of patients who require a lot of time and attention. On some shifts, a nurse may be responsible for 2 critically ill patients, but can be more depending on staffing situations for the shift. Each of those patients may need constant monitoring, medications, extreme life support, communication with families, coordination with doctors, and many other parts of care throughout the day. When staffing is stretched, nurses have to divide our time in ways that none of us want. We always work hard to provide the care that our patients deserve, but we know that having more consistent staffing standards would allow us to spend more time inside with our patients. That time matters. It means more opportunities to notice subtle changes, answer families' questions, and provide the kind of thoughtful, attentive care that every single patient deserves. That is why the nurses in the ICU are proposing clear, evidence-based staffing standards set by the American Association of Critical Care Nurses that are used in hospitals across the nation. These standards set a minimum of 1 nurse to 2 critically ill or critically injured patients that would help to ensure that we are always responsible for managing. That would help ensure that we are always responsible for a manageable number of patients so we can focus on delivering the highest level of care. We believe these standards would benefit everyone. They would support nurses and prevent burnout. They would help patients receive more intensive care, and they would help strengthen our hospital by supporting the dedicated professionals who work there every day. We want to work collaboratively with UPMC to achieve this. UPMC has tremendous resources, and by investing in national, evidence-based, sophisticated standards, Magee has the opportunity to continue leading the way in women's and family health. When I think about the future, I imagine a hospital where every nurse has the time that they need with their patients. A hospital where families feel supported and heard, and where the nurses can fully focus on the care that brought us into the profession in the first place. That is the vision that we are working towards here. And with the right staffing standards in place, I believe that it is possible.
Thank you, Dan, for sharing your experience. In closing, I want to say that in order to address the crisis facing reproductive and family health, we have to elevate care standards at Magee, the area's preeminent women's care provider. And in order to address the nursing crisis, we need to elevate nursing standards at UPMC, our Commonwealth's largest healthcare system and employer. We look forward to working collaboratively with UPMC to invest in the staffing standards that nurses, our patients, and our community deserve. Now we're going to begin negotiations where we will present our staffing proposals to UPMC. We'll be available individually for interviews for a few minutes if anyone has any follow-up questions. Thank you very much.
You too.